It is funny how we tend to picture the human body. We imagine this pristine, static temple, like a marble statue where everything is perfectly still and serene.
Yeah, totally static.
Right. But if you were to somehow shrink down and, take a microscopic tour of the gastrointestinal tract, you would realize very quickly that it is not a temple at all.
Not even close.
No, it's a 20-foot-long, incredibly loud, highly coordinated factory assembly line folded up inside your abdomen.
It really is a relentless, wet, dynamic conveyor belt. I mean, you are talking about a system that employs aggressive mechanical grinders, chemical solvent dispensers that rival, like, industrial vats.
Yeah.
And highly specialized absorptive surfaces. And all of it has to work in absolute, uninterrupted synchrony just to process your lunch.
Right. And so today, we're going to look at what happens when that entire 20-foot assembly line, just violently, without any warning, grinds to a halt.
Which is terrifying.
It really is. Think of a massive multi-lane highway system moving heavy freight from point A to point B. What we are exploring today in this deep dive is the ultimate, catastrophic, physiological traffic jam.
The small bowel obstruction.
Exactly. The small bowel obstruction. We are going to decode the incredibly strange and honestly sometimes totally counterintuitive ways our bodies try to heal themselves after a trauma.
Yeah.
And how that very healing process ends up causing massive life-threatening blockages. Because this isn't just about plumbing.
No, the pathology here is staggering because it sits right at the intersection of biochemistry, fluid dynamics, and raw mechanical engineering.
Right.
It is one of those conditions where you see the body's evolutionary survival mechanisms completely backfire in the modern world.
And to understand the traffic jam, we have to start by looking at how the highway operates on a normal Tuesday. For a long time, I feel like the gut was treated in basic biology classes as, like, a dumb tube.
Oh, absolutely.
Just a passive plumbing system where food falls down, gets mashed up, and comes out the other end. But that really isn't giving the body nearly enough credit, is it?
Not even close. Calling the gut a dumb tube is, well, it's like calling a supercomputer a fancy abacus. To appreciate the pathology of an obstruction, you must first respect the sheer complexity of the baseline physiology.
So how complex are we talking?
Extremely. The primary mission of the gastrointestinal tract is the assimilation of a meal. When you swallow food, you are introducing large, complex, totally unabsorbable macromolecules into your system.
Right, because the body can't just use a whole piece of bread.
Exactly. The body cannot use a piece of a hamburger bun. It has to aggressively dismantle it.
So it basically has to turn a solid meal into a liquid soup before it can extract anything of value.
Yes, an aqueous solution. And it achieves this through overlapping processes. First is motility, which is the physical grinding, churning, and forward propulsion of the material.
Okay.
Then you have secretion, where the glands along the tract pump in massive amounts of water, ions, and powerful enzymes.
That's the chemical solvent part.
Right. That leads to digestion, which is the actual chemical dismantling of the molecules. Only then can you have absorption.
Which is moving those newly freed microscopic nutrients across the intestinal wall.
Yes, moving them into the bloodstream or the lymphatic system, and then whatever's left over undergoes elimination.
But the thing is, the macronutrient content of what we eat varies wildly, right? Eating a massive bowl of leafy green kale requires a completely different chemical solvent than eating, say, a heavy, fat-laden ribeye steak.
Oh, absolutely.
So if the gut isn't a dumb tube, how does it know what solvent to pump into the vat at any given time?
The coordination required for that is mind-boggling. The GI tract actually has to detect the exact chemical makeup of the food currently sitting inside it.
Wow.
Yeah, and then mount a highly specific, custom-tailored physiological response. It relies on 3 principal control systems to do this.
Okay.
You have the endocrine, the paracrine, and the neural systems.
Okay, let's break those down because the communication network here is fascinating. Let's start with the endocrine system. When we hear endocrine, we usually think of the thyroid or, the adrenal glands. But the gut has its own.
It does. Endocrine regulation in the gut relies on specialized sensing cells embedded directly in the intestinal wall.
Okay.
They're called enteroendocrine cells. And these are not clustered together in a single organ, like the thyroid.
Right.
They are scattered throughout the lining of the stomach and intestines. What is truly brilliant about these cells is their physical orientation. Most of them are what we call open-type cells.
Meaning they are exposed to the element.
Physically, yeah. Their apical membrane, which is their top surface, literally protrudes out into the lumen.
The hollow inner space of the intestine.
Exactly. They are physically bathing in the digesting food. They have microvilli that are chemically tasting the environment.
Tasters. That's wild.
Yeah. They have receptors that can bind to specific amino acids or sense a drop in pH or detect the presence of free fatty acids.
So they're like little chemical sentinels. If a piece of that ribeye steak floats by, the sentinel tastes the fat and the protein.
Yes.
What does it do with that information once it tastes it?
Well, once the receptors on the top of the cell are triggered, the basolateral membrane, the bottom of the cell that faces the internal blood vessels, releases specific regulatory peptides or hormones directly into the bloodstream.
Okay.
Those hormones then travel systemically to distant target organs. A classic example is cholecystokinin, or CCK.
GCK.
Right. When those sentinels in the upper intestine taste fat, they dump CCK into the blood. The CCK travels up to the pancreas and tells it to release fat-digesting enzymes.
Oh.
It also travels to the gallbladder and forces it to contract, squeezing bile into the intestine to emulsify the fat.
So the food never even touches the pancreas or the gallbladder.
Nope. But the gut coordinates their actions perfectly from a distance.
That's the long-distance systemic communication.
Yeah.
Like corporate headquarters sending a memo to the warehouse.
That's a great way to put it.
But you mentioned the paracrine system as well. That's more localized, right?
Localized and highly targeted. In paracrine communication, the chemical messenger does not enter the bloodstream at all.
Okay, so where does it go?
Instead, it diffuses through the interstitial space. That's the fluid sitting between the cells. It moves through that to reach its immediate neighbors. It is literally like whispering to the person sitting at the desk next to you.
But why would the gut need to whisper locally if it already has the systemic blood network?
For rapid, fine-tuned control of localized environments. Take stomach acid, for example. There are specific cells in the stomach lining that release a molecule called histamine.
Right.
The histamine diffuses just a microscopic fraction of a millimeter to bind to neighboring parietal cells, commanding them to pump out hydrochloric acid.
Okay.
But if the local environment gets too acidic, another local cell releases somatostatin. Somatostatin acts as the emergency brake.
So it tells them to stop.
Exactly. It diffuses over to the histamine cells and shuts them down. It's a localized negative feedback loop, ensuring the acid production stays perfectly balanced without needing to involve the entire circulatory system.
So we had the endocrine sending emails, the paracrine whispering across the desk. That brings us to the neural control. And this is where I think the whole second brain concept really comes into play. We are talking about actual nerves wiring the gut.
The neural control is incredibly robust. It is divided into extrinsic and intrinsic systems.
Extrinsic being outside.
Right. Extrinsic means the commands are coming from outside the gut, down from the central nervous system. This is primarily your autonomic nervous system.
Okay.
The parasympathetic branch, the rest and digest mode, is driven heavily by the vagus nerve. The vagus nerve wanders all the way down from your brainstem, through your chest, and wires into your esophagus, stomach, pancreas, and upper intestines.
So it's a direct physical wire from the brain.
Exactly. When you are relaxed and eating, the vagus nerve is firing, promoting motility and secretion. The sympathetic branch, your fight or flight mode, does the opposite.
Right. If you're terrified, you don't want to be digesting a sandwich.
Right. It inhibits digestion so your body can divert blood to your muscles.
But here's a question. If I severed the vagus nerve, if I completely disconnected the gut from the brain, the gut still works, doesn't it? It doesn't just sit there paralyzed.
It absolutely continues to function, and that is due to the intrinsic system, known as the enteric nervous system.
The second brain.
This is where the second brain moniker is entirely earned. The enteric nervous system is a massive, incredibly dense network of neurons embedded directly within the muscular walls of the gastrointestinal tract.
How dense are we talking?
We are talking about roughly the same number of neurons as you have in your entire spinal cord.
That is wild. It's an autonomous thinking network wrapped around the pipe.
It really is. It controls the intricate wave-like muscle contractions known as peristalsis. It coordinates the mixing segmentations. It can sense the physical stretch of the bowel wall when a bolus of food enters and autonomously coordinate the muscles behind the food to contract and the muscles in front of the food to relax.
Pushing it forward.
Exactly, pushing the material forward. It handles all this local choreography completely independently of the brain.
And to make all of this mixing and moving possible, this entire factory has to be a wet environment. Like, you can't push dry powder through 20 feet of tubing. How does the gut manage the sheer volume of water required?
Through the precise manipulation of electrolytes, the intestinal epithelium doesn't just pump water directly.
Oh, it doesn't.
No. Instead, it uses specialized ion transport proteins to actively pump electrolytes like sodium and chloride across the cell membranes. Once those ions are pumped into the lumen, physics takes over.
Osmosis.
Exactly the mechanism. Water passively follows the ions to maintain isosmolality.
Meaning a balanced concentration on both sides.
Right, a balanced concentration of dissolved particles on both sides of the membrane. As the sodium is pumped into the hollow tube, water is dragged right along with it through the microscopic gaps between the cells,
Creating the soup.
creating that liquid, highly dynamic environment necessary for the enzymes to work.
All right, so we have a clear picture now. We have a 20-foot, liquid-filled, sensing, thinking, hormonally balanced conveyor belt that can digest anything from a cracker to a steak.
It is an engineering marvel.
It truly is.
But if it relies on that continuous forward motion, what physically happens when we drop a concrete barricade into the middle of the highway? Let's talk about the obstruction itself.
Right. The clinical definition of a small bowel obstruction, or SBO, is the failure of propulsion of intestinal contents aborally,
Imborally.
which simply means away from the mouth down toward the colon.
Okay. And there are two main categories here, right? Because the highway can stop for different reasons. You could have a physical barricade, or the trucks themselves could just run out of gas and stop driving. That is a perfect analogy for the two main types. The first is a functional motility problem, medically termed an ileus.
An ileus.
In an ileus, there is no physical blockage. The tube is completely open. But the neuromuscular machinery, that enteric nervous system we just discussed, simply goes on strike.
It just quits.
The muscle becomes paralyzed, usually due to severe inflammation, a systemic infection, or ischemia. The contents just sit there.
But the other type, the one we are focusing on today, is the mechanical obstruction. This is the physical barricade.
Yes. Mechanical blockages account for the vast majority, over 80% of all bowel obstructions. And when a patient presents with a mechanical obstruction, doctors have to classify it immediately.
Why immediately?
Because the classification entirely dictates the surgical approach and the urgency.
Let's walk through that classification. If I am the doctor, what are the different ways I categorize this traffic jam? I imagine the first question is, where is the physical object?
We call that classifying by etiology, the origin of the blockage relative to the intestinal wall. Is the problem intraluminal?
Meaning inside the lumen.
Meaning, is there something physically sitting inside the hollow tube blocking the flow?
Like what?
This could be a swallowed object, a massive gallstone that has eroded its way through the gallbladder directly into the bowel, or a bezoar.
A bezoar.
Yeah, which is a tightly packed, indigestible mass of hair or vegetable fibers. It could even be a massive bundle of parasitic worms, like Ascaris, physically clogging the pipe.
Okay, that is a terrifying image.
Uh-huh.
But intraluminal is a clog inside the pipe. What's next?
Next is intramural. This means the problem is originating within the actual tissue wall of the pipe itself.
Okay, like the wall is swollen.
The most common example here is a stricture. In diseases like Crohn's, chronic inflammation causes the bowel wall to build up thick fibrotic scar tissue.
Right.
Over time, the wall thickens so much that the internal diameter of the tube shrinks down to a pinhole, obstructing flow. An intramural tumor growing out of the muscle layer would also fit this category.
And the final category is extrinsic, something outside the pipe squeezing it shut.
Precisely. Extrinsic causes are the most common by far. This is an external force compressing the bowel from the outside.
Like a tumor.
It could be an external tumor, a hernia where the bowel gets trapped and pinched in a tight muscular opening, or, as we will discuss heavily later, an adhesion.
An adhesion.
Yeah, a band of scar tissue wrapping around the bowel and kinking it like a garden hose.
Aside from where it is, we also classify how bad it is.
We classify by the degree of obstruction. Is it partial, where perhaps some liquid and small amounts of gas can still squeeze past the barricade?
Huh?
Or is it complete, where absolutely nothing is getting through? We look at the speed of onset. Is it a chronic, slow worsening stricture or an acute, sudden twist?
And then there's the progression.
And most importantly for survival, we look at the progression. Is it a simple obstruction where the tube is blocked but the blood supply feeding the tissue is totally fine?
Right.
Or has it progressed to a strangulated obstruction where the arteries and veins are choked off and the tissue is actively dying?
Let's talk about the symptoms, because I think a lot of people might confuse a bowel obstruction with like really bad case of food poisoning or constipation. If a patient is experiencing a mechanical blockage, What are the red flags? The sources mention 4 cardinal symptoms.
The 4 classic hallmarks are colicky abdominal pain, nausea and vomiting, abdominal dilation, and obstipation.
The word colicky always makes me think of a crying infant.
Yeah.
But in this adult context, it refers to the specific nature of the pain. It's not a constant, dull ache. It comes in intense, rolling waves. Why does it do that?
It goes back to that intrinsic nervous system. When the enteric nerves sense a complete physical blockage, they don't just give up.
Right, they try to fix it.
Their programmed response is to push harder to clear the pipe. The smooth muscle of the bowel goes into hyperperistalsis.
Oh, wow.
It violently and rhythmically contracts against the fixed, immovable obstruction. As the muscle squeezes with incredible force, the patient experiences severe, cramping agony.
And then it stops.
When the muscle exhausts itself and relaxes for a minute, the pain subsides. Then the wave hits again.
And that explains the nausea and vomiting, too. If the highway is closed and the muscle is violently squeezing, but the material can't go forward, there is literally only one other direction for it to go.
The backed up fluids, gastric juices, and bile have to vent upwards. The abdominal dilation or physical swelling of the belly happens because the area of the bowel proximal to the blockage, the area upstream, is ballooning outward like a tire being overinflated.
And obstipation. I know constipation is struggling to pass stool. Obstipation sounds like the final boss of constipation.
Obstipation is the absolute total cessation of passing anything. Not only is there no stool, but there is no flatus, no passing of gas whatsoever. Nothing is getting past the barricade to reach the colon.
But here's where I really need to push back on the plumbing analogy we've been using. If the pipe under my kitchen sink gets clogged, the water backs up. Maybe it spills over the rim of the sink. But the pipe itself doesn't care. It just sits there. Why is a blocked pipe in the human body considered a massive, life-threatening emergency?
That's a crucial distinction.
Like, if no more food is going in, why can't the body just hit pause and wait for a doctor to fix it? Why does it turn lethal so quickly?
This is the crux of the pathology. You have to remember that unlike a PVC pipe under your sink, the bowel is living, breathing tissue. It requires a constant supply of oxygenated blood. It is highly vascularized.
Right.
When an obstruction occurs, it sets off a devastating self-amplifying cascade of pressure that destroys that blood supply.
Walk me through that cascade, minute by minute. What is happening upstream of the barricade?
Initially, as the fluids and digested food back up, the bowel dilates. This dilation is rapidly worsened by 2 things. First, every time the patient swallows or even breathes heavily in pain, they swallow air, which travels down and gets trapped.
Okay, so air is building up.
Second, the small intestine is full of bacteria. Usually, the food moves through too quickly for them to do much.
Right.
But now, the food is stagnant. It is sitting in a warm, dark, liquid vat. The bacteria go into a feeding frenzy, fermenting the sugars and producing massive amounts of metabolic gas.
So the balloon is filling with fluid from the gut, air from the lungs, and gas from the bacteria. The pressure is building.
Rapidly. As the bowel stretches tighter and tighter, the intestinal wall itself becomes edematous. It swells up with fluid. Because the cells are stretched and damaged, the small bowel completely loses its absorptive function.
Oh, the ion pumps we talked about.
Remember those, they fail. Instead of absorbing water out of the lumen, the damaged wall starts weeping fluid into the lumen, adding to the volume.
Making it even worse.
Exactly. The patient is vomiting constantly, losing critical potassium and chloride. They become rapidly, profoundly dehydrated.
The blood volume is dropping because they're losing fluid, which means the kidneys start to fail.
You see oliguria, a massive drop in urine output, and azotemia, which is the buildup of toxic nitrogen waste in the blood, because the kidneys don't have enough fluid volume to filter the blood properly.
But the truly fatal mechanism is happening locally at the bowel wall.
It's a pressure problem, isn't it? The tissue is being stretched too thin. It is pure physics. As the volume of trapped fluid and gas increases, the intraluminal pressure, the physical pressure inside the hollow space, rises exponentially.
Right.
The blood vessels that feed the bowel wall run through the muscle layers. Veins have very thin walls and operate at low pressure. Arteries have thick muscular walls and operate at high pressure.
So as the pressure inside the tube builds, it presses against the wall, and the weak, low-pressure veins get crushed flat first.
Exactly. The intraluminal pressure exceeds the venous pressure, the veins collapse, but the high-pressure arteries are still pumping blood into the tissue.
Because they're stronger.
Right. Blood is going in, but it can't drain out. The bowel wall becomes massively engorged and congested with trapped, deoxygenated blood.
Oh.
It swells even further, which creates more pressure.
A vicious cycle.
A terminal cycle. Eventually, the tissue swells so much that the local pressure exceeds the arterial pressure. The arteries collapse.
So the supply is totally cut.
Now, no fresh oxygenated blood can get in. The tissue suffers from acute ischemia, oxygen starvation. Within hours, that ischemia progresses to full-blown necrosis. The cells die and rot.
Dead tissue can't hold tension.
Dead tissue loses all structural integrity. The paper-thin necrotic bowel wall simply tears open under the massive internal pressure. It perforates.
Which means everything spills.
All of that backed up, highly infectious, bacteria-laden fluid spills directly into the sterile peritoneal cavity of the abdomen. The patient develops massive internal sepsis, septic shock, and without immediate heroic intervention, they will die.
So what started as a physical barricade evolves into a catastrophic circulatory infectious failure, which brings us to a terrifying statistic. We need to talk about what is actually causing these barricades. The numbers from the sources indicate that hernias cause 25%, tumors cause 10%, inflammatory diseases 9%. But the undisputed king, causing a massive 56% of all small bowel obstructions, are adhesions.
Over half of all cases, it is the dominant etiology.
That means for the majority of people suffering through this terrifying cascade of tissue death we just outlined, the barricade was built by their own body.
Yes.
And adhesion is scar tissue. Why does the body betray itself so aggressively, particularly after someone has had a completely unrelated abdominal surgery?
To understand this biological betrayal, we have to zoom way down and look at the pathophysiology of how the inside of your abdomen heals.
Okay.
Simply put, an adhesion is an abnormal, highly inflammatory attachment between two tissue surfaces that should normally be separate and glide freely over one another.
Got it.
To grasp why the body builds these, you have to contrast how the internal organs heal versus how your skin heals.
Okay, let's use the skin as the baseline. If I accidentally slice my arm with a kitchen knife, I know how that heals. A scab forms, and then the skin slowly grows back from the edges of the cut inward, pulling the wound closed.
Correct. The skin undergoes what we call reepithelialization from the periphery. It is a slow, methodical bridging of the gap from the outside edges.
Right.
But the peritoneal cavity, the slick, fluid-filled sac that holds all your abdominal organs, operates on a completely different set of biological rules. The peritoneum is lined by a single, incredibly delicate layer of mesothelial cells.
Just one layer.
Just one. And these cells are very loosely anchored to their underlying basement membrane. They are incredibly fragile.
How fragile are we talking?
If a surgeon wearing a sterile latex glove simply brushes their hand against the bowel, that friction is enough to shear off thousands of mesothelial cells.
Just from a brush.
Even just exposing the internal organs to the dry, ambient air of an operating room for a few minutes will cause the cells to desiccate and die.
So anytime a surgeon opens the abdomen, microscopic damage is happening everywhere, not just where the scalpel cuts. How does the peritoneum heal that massive diffuse damage? It doesn't heal from the edges.
No, it doesn't. Operative defects in the peritoneum are reperitonealized by the implantation of new mesothelial cells simultaneously across the entire surface of the defect.
It's like instead of grass slowly creeping in from the edges of a bare dirt patch, you just throw thousands of grass seeds across the entire patch all at once.
It is simultaneous, widespread regeneration, and the trigger for this process is aggressive. When those delicate mesothelial cells are damaged, detached, or exposed to air, they sound a massive biological alarm.
Okay.
They initiate a localized cytokine storm. The injured cells immediately express cell adhesion molecules on their surface, and they release chemotactic factors.
Chemotactic factors are basically chemical flare guns, right? They're signaling the immune system to send in the heavy machinery.
You are calling in the macrophages. A massive influx of inflammatory macrophages rushes to the site of the microscopic injury. And these macrophages are not subtle. They are aggressive cleanup crews.
They don't mess around.
Once they arrive, they start pumping out powerful inflammatory cytokines.
The sources mention some specific culprits here. Interleukin-1 and tumor necrosis factor.
Interleukin-1, or IL-1, and tumor necrosis factor, TNF, are released in huge volumes. These two molecules act as potent triggers to induce the production of interleukin-6.
IL-6.
And IL-6 is fiercely adhesiogenic. Its primary job is to promote the formation of sticky, fibrous attachments.
Right.
At the exact same time, because the tissue has been cut or handled, it is experiencing local hypoxia, low oxygen. The hypoxic tissue panics and overexpresses vascular endothelial growth factor, or VEGF.
And vascular means blood vessels. So the tissue is screaming for new bloodlines to be built to bring in oxygen.
VEGF triggers the rapid growth of new abnormal capillaries into the injured area. Simultaneously, the macrophages are also releasing transforming growth factor beta.
TGF.
Right. TGF-β is a massive stimulator of fibroblasts. Fibroblasts are the cellular construction workers whose sole job is to build structural extracellular matrix. They build the dense collagen that makes up tough scar tissue.
So let me get this straight.
Yeah.
The surgeon makes a tiny nick. The body panics, throws out chemical flares, calls in an army of aggressive immune cells, triggers massive inflammation, orders new blood vessels to be rapidly built, and commands construction cells to start pouring dense collagen scar tissue over everything.
Yes.
It is just throwing the entire biological arsenal at the wound.
It is a massive, disproportionate response, but here's the critical part. This aggressive response happens every time you are injured.
Right.
When you get a deep cut on your arm, you also form a scab. A scab is essentially a sticky matrix of a protein called fibrin. It holds the tissues together while they heal underneath, but eventually the scab dissolves and falls off.
Exactly. Why don't these internal scabs, these adhesions, just dissolve once the bowel is healed?
That brings us to the core of the biological failure, fibrinolytic failure. Normally, during the healthy healing of the peritoneum, a fibrin-rich exudate coats the injury. It is a sticky, gelatinous gel that acts as a temporary biological bandage.
Okay.
In a healthy system, once the tissue underneath is repaired, the body initiates a process called fibrinolysis. That's the active breaking down of that fibrin gel.
There's an enzyme that chops up the gel.
The star player in fibrinolysis is TPA, tissue plasminogen activator.
Wait, TPA, isn't that the drug they inject into stroke patients to bust up blood clots in their brain?
It is the exact same molecule. Your body produces it naturally.
Oh, wow.
TPA converts an inactive protein called plasminogen into its active form, plasmin. Plasmin is the molecular scissors that physically chops up the sticky fibrin matrix, dissolving the temporary scab.
Okay, so if the body has molecular scissors, why doesn't it cut down the adhesions?
Because the primary source of natural TPA in the abdomen is the intact, healthy mesothelial cells. Yes. When the mesothelium is stripped away or damaged during surgery, the local factory producing the TPA is completely deleted. The scissors are gone.
That's terrible.
Furthermore, the massive trauma of the surgery causes the surrounding tissues to spike their production of PAI plasminogen activator inhibitors. These are molecules specifically designed to block any remaining TPA from working.
So the TPA levels plummet and the anti-TPA levels skyrocket.
The fibrinolytic system fails entirely. The body creates the massive, sticky fibrin gel bandage to protect the surgical wound, but it completely loses the biochemical ability to dissolve it later.
Meaning that temporary gel just sits there? What happens to it?
Because the fibrin isn't cleared away, the matrix stabilizes and becomes a permanent fixture. Those fibroblasts we talked about earlier, the construction workers migrate directly into this stable gel.
Right into it.
They proliferate, set up shop, and start replacing the gel with heavy, dense extracellular matrix, including incredibly tough collagen fibers.
And the blood vessels.
Those new blood vessels, driven by VEGF, grow into the matrix, providing it with a permanent blood supply. What should have been a flimsy, temporary, fibrinous adhesion that dissolves cleanly in 3 days becomes a permanent, highly vascularized, tough, fibrous band that locks the surrounding organs together like steel cables.
It is like the body ran out of temporary Post-it notes to hold the tissue together while it healed, and decided in a panic to use heavy-duty industrial superglue instead. And because the intestines are packed so tightly together, you've accidentally superglued two moving parts of a massive engine permanently together.
That analogy is biologically spot on. You have locked a dynamic, moving tube to a fixed point. When the bowel tries to undergo normal peristalsis, it pulls and twists against that fixed scar band. Eventually, it kinks, folds over itself, or it gets squeezed completely shut by the band.
And the statistics on this are just deeply unfair. The sources note that this adhesion formation begins literally hours after the surgical incision is made. While you are still in the recovery room, the superglue is setting.
Yes.
But the actual obstruction might not happen for years.
The timeline is highly variable and depends heavily on what kind of surgery you had. If you have an appendectomy, the median time to your first bowel obstruction is about 2 years.
Okay.
If you have colorectal surgery, it's faster, 0.9 to 1.4 years. But the risk from gynecological surgeries, particularly those deep in the pelvis, is staggering.
Like what?
You could have a hysterectomy or surgery for severe endometriosis, and the median time to your first obstruction can be up to 7 years later.
You could have surgery, totally recover, forget about it entirely, and a decade later suddenly find yourself screaming in an emergency room with a dying bowel.
It happens all the time. The surgical technique matters immensely, too. Open surgeries, the traditional laparotomy where the surgeon makes a long incision down the middle of the belly, exposing all the organs to air and using dry gauze sponges, cause vastly more diffuse trauma to the mesothelium than laparoscopic surgeries.
Laparoscopic being the tiny keyhole incisions with cameras and long instruments.
Yes, the difference is profound. For example, the incidence of a small bowel obstruction after an open total abdominal hysterectomy is nearly 15.6%.
That's high.
But if that exact same procedure is performed laparoscopically, where the organs stay inside a closed, humid environment and aren't handled as aggressively, the incidence drops to nearly 0%.
That is an incredible argument for minimally invasive surgery.
Yeah.
But when you look at the whole picture, the cytokine storm, the macrophages, the missing TPA, it just feels like a massive design flaw in the human body. Why would we evolve a healing mechanism that eventually kills us?
It highlights a tragic evolutionary irony. Adhesions are not a design flaw. They are the body's desperate, over-enthusiastic attempt to survive a catastrophic trauma.
How so?
Think about our evolutionary history. Before the advent of sterile surgical suites 150 years ago, the only time a human being's abdominal cavity was ever opened was due to a horrific trauma, being gored by an animal or stabbed in battle.
And in those situations, you don't care about a bowel obstruction 10 years later. You care about not bleeding to death in 10 minutes.
Exactly. The body doesn't know what a surgeon is. It just senses massive trauma, massive bleeding, and the high likelihood of intestinal bacteria leaking into the abdomen. Forming a massive, sticky scar block to physically plug holes, stop bleeding, and wall off infection was an incredibly successful short-term survival mechanism.
You trade long-term motility for immediate survival.
The tragedy is that this ancient aggressive survival mechanism completely backfires in the era of modern, sterile, elective abdominal surgery. The body doesn't realize we are trying to help. It just reacts to the scalpel by supergluing everything down.
Okay, so adhesions are the slow-burning long-term threat that account for the majority of blockages. But our sources also detail a few anatomical traps that are much rarer, but incredibly sudden and highly lethal.
Yes.
I want to spend some time on internal hernias and closed-loop obstructions, because from what I'm reading, when these happen, the clock isn't just ticking, it's practically vibrating.
These are the clinical presentations that make emergency surgeons sprint down the hallway. A standard obstruction, what we've discussed so far, is usually an open loop.
Meaning one block.
Right. There is a single block at point B. Everything from the mouth down to point B gets backed up. It's dangerous, but it progresses somewhat linearly. A closed-loop obstruction is a completely different biomechanical nightmare. This occurs when a segment of bowel is obstructed at 2 separate points along its course, but those 2 points are trapped at a single physical location.
I am really trying to visualize this. The bowel is a continuous hose. How exactly does a single segment get pinched off at both ends simultaneously?
Think of a clown making a balloon animal. He has a long, straight, inflated balloon. If he takes the middle of that balloon, folds it in half so 2 parts of the tube are touching, and then pinches and tightly twists those 2 touching parts together, he has just isolated a small loop of the balloon.
I see it. So that twisted loop in the middle is now sealed off from the rest of the balloon. The air inside that specific loop can't go forward and it can't go backward. It is a completely trapped chamber.
That is a closed loop. And the reason it is so astronomically lethal is the pressure dynamic. In an open obstruction, the pressure can slowly vent backwards towards the stomach. In a closed loop, the pressure have absolutely nowhere to go.
Oh, man.
The bacteria inside that isolated loop continue fermenting, producing gas. The tissue continues to weep fluid. The intraluminal pressure inside that specific isolated loop rises exponentially faster than in a normal obstruction.
And we just established that rising pressure collapses the blood vessels.
Yeah.
So the tissue in that closed loop is going to die much, much faster.
It is worse than that. When the bowel twists to form that loop, it doesn't just twist the hollow tube. You have to remember how the bowel is anchored inside the body.
It isn't just floating free.
No, it is attached to the back of the abdominal wall by a massive fan-like sheet of tissue called the mesentery.
The mesentery. What does that do besides hold things in place?
The mesentery is the leash that tethers the bowel. But crucially, running all through that thin sheet of tissue are all the arteries and veins that supply blood to the intestines. Every drop of blood entering or leaving the bowel has to travel through the mesentery.
Oh, I see where this is going. If you twist the balloon animal, you are twisting the leash as well.
Yes. When the bowel twists on itself, a condition known as a volvulus, it physically twists the mesentery around like a wrung-out wet towel. You are not just causing an internal pressure problem inside the bowel, you are applying a physical, mechanical tourniquet directly to the main arteries and veins feeding that entire section of the gut.
You are instantly choking off the blood supply at the source.
Immediate, severe, mechanical vascular compromise. This is why the risk of strangulation is so profoundly high.
How fast?
Gangrene, which is the total death and putrefaction of the tissue, can set in as quickly as 6 hours from the onset of the patient's pain.
That is terrifying.
The mortality rate for a closed-loop obstruction jumps dramatically, sitting anywhere from 10 to 35% depending on how fast they get to an operating room.
Just 6 hours from a stomachache to rotting tissue. What causes the bowel to suddenly fold and twist on itself like that?
Often, it is caused by a single, dense adhesion band. The band acts as a fixed pivot point. A loop of bowel slides under the band, gets stuck, and as it struggles to free itself with hyperperistalsis, it spins around the band, twisting its mesentery.
Wow.
But another major, highly complex cause of a closed loop is an internal hernia.
Now, I think most people, when they hear the word hernia, they picture an inguinal hernia in the groin, or maybe an umbilical hernia popping out of the belly button after lifting something heavy. It's a bulge under the skin where the bowel is poking out through a tear in the abdominal wall muscles. How is an internal hernia different?
An internal hernia is completely invisible from the outside. The abdominal wall is perfectly intact. An internal hernia is defined as the protrusion of an abdominal organ, usually the highly mobile small bowel, through an aperture or a hole that exists deep within the peritoneal cavity itself.
Holes inside the abdomen. Where?
Specifically through holes in the mesentery, or gaps in the omentum, which is the fatty apron covering the intestines, or into natural anatomical recesses and folds of the peritoneum.
Okay.
The bowel slips through one of these internal pockets, gets trapped, the opening acts like a noose, and the bowel swells until it chokes itself off. They are very rare, accounting for less than 1% of all small bowel obstructions.
Which makes them a massive diagnostic challenge for doctors. Are we born with these internal holes or do we develop them?
Both. We divide them into congenital and acquired internal hernias. Congenital hernias occur through natural developmental pockets that formed improperly when the fetus was first growing in the womb.
How does that happen?
The embryology of the human gut is incredibly complex. The intestines actually grow outside the fetus's body initially and then rotate and pull back inside, fusing to the back wall. Sometimes those fusion lines leave small pockets.
Like a secret trapdoor that never fully sealed?
Precisely. The most common congenital types are periduodenal hernias. Specifically, the left periduodenal hernia, where the small bowel gets trapped in an abnormal fold of peritoneum near the fourth part of the duodenum, a pocket known as Lanzert's fossa.
Lanzert's fossa.
Right. Another congenital type is a transmesenteric hernia, where there is simply a developmental defect, a literal hole in the broadsheet of the mesentery itself. The bowel can easily slip through that hole and get trapped on the other side.
Okay, so some people are just born with an anatomical trap waiting to spring. What about the acquired ones? How do you acquire a hole in your mesentery?
Acquired internal hernias happen through holes created by physical trauma, like a severe car crash that tears the mesentery. But far, far more commonly, they are created by surgeons.
Surgeons again.
And what is fascinating and deeply concerning to the surgical community is the massive rising trend of acquired internal hernias over the last 2 decades.
Driven by what?
By the explosive popularity of modern bariatric surgeries, specifically the Roux-en-Y gastric bypass for weight loss.
How does shrinking someone's stomach cause a hernia in their intestines?
To perform a Roux-en-Y bypass, the surgeon doesn't just staple the stomach. They have to completely reroute the plumbing to bypass a large section of the absorptive intestine.
Right.
To do this, they cut the small intestine in half. They bring the lower segment up and attach it directly to the new tiny stomach pouch. Then they take the upper segment that is still draining the liver and pancreas and attach it further down the line into the side of the lower segment.
That sounds like a massive rerouting job.
It is. And to physically move those segments of bowel around to their new locations, the surgeon has to artificially cut holes through the patient's mesentery to pass the bowel through.
Oh, I see.
Now, surgeons are meticulous about trying to suture these artificial mesenteric defects closed before they finish the operation. But sutures can fail.
And these patients are undergoing the surgery specifically to lose massive amounts of weight. Does that play a role?
That is the compounding factor. The mesentery is naturally packed with fat. As the patient rapidly loses 100 or 150 pounds over the next year, the fat inside their mesentery completely melts away. The tissue shrinks.
Leaving a gap.
Yes, the small sutured hole that the surgeon closed suddenly loosens and widens as the fat disappears. A gap opens up. Years after the bypass, a loop of small bowel can easily slip through that artificial hole, become trapped, twist, and strangulate.
Diagnosing that must be an absolute nightmare for an ER doctor. I mean, it's a hidden twist inside a patient whose anatomy has already been surgically rearranged.
The clinical presentation spans a massive, confusing spectrum. On one end, a patient might present with chronic, episodic, vague abdominal pain that has bothered them for years.
Like it comes and goes.
Yes. This happens when a loop of bowel slips into the internal hernia defect after a large meal, gets a little cramped, causing pain, but then, as the bowel moves, it spontaneously slips back out. We call this a reducible hernia.
So they go to the ER in agony, but by the time they wait 3 hours in the waiting room and finally get a scan, the bowel has slipped out and everything looks perfectly normal.
Exactly. The evidence vanishes. These patients often go years being misdiagnosed with irritable bowel syndrome, food intolerances, or even being told their pain is psychosomatic or psychiatric.
That's awful.
But then, on the terrifying other end of the spectrum, that bowel slips into the hole one day, twists, swells, and becomes completely incarcerated. It cannot slide back out.
And then the 6-hour clock starts.
Exactly. The venous pressure rises, the arteries collapse, and they rapidly progress to life-threatening acute ischemia.
Which brings us to arguably the most critical juncture in this entire process, the diagnostic detective work. If you have a patient writhing in pain, and you know the tissue might be dying in a matter of hours, especially in a closed-loop scenario, how do doctors figure out exactly what is going on inside the body without just blindly slicing the patient open immediately?
The clinical investigation has evolved immensely, and it relies on a hierarchy of imaging. When a patient presents with those cardinal symptoms, colicky pain, vomiting, distension, the investigation almost always starts with a very old, very fast, widely available technology.
Plain radiographs or basic x-rays.
Right.
But what can a simple flat x-ray actually show you about a three-dimensional tangle of intestines?
They are looking for the classic triad of small bowel obstruction. They typically take a supine x-ray with the patient lying flat on their back and an upright x-ray with the patient standing or sitting up.
Let's break down the triad. What is the first sign?
The first is significantly dilated loops of small bowel. The normal, healthy small bowel is usually less than 2.5 centimeters in diameter. If a radiologist looks at the x-ray and measures loops that are greater than 3 centimeters in diameter, that is highly suspicious for a backup.
And the second sign? I'm guessing this requires the upright x-ray.
Yes, the second sign relies on gravity. They look for air fluid levels.
Air fluid level.
Because the bowel is obstructed and paralyzed, it acts like a stagnant tank. The fluid pools at the bottom and the gas rises to the top. This separation creates a distinct, perfectly flat, horizontal line of fluid with a black, dome-shaped pocket of air above it.
Okay, I can picture that.
If you see multiple air fluid levels that are wider than 2.5 centimeters, or if you see air fluid levels at radically different heights within the exact same loop of bowel, suggesting the tube is kinked, it strongly indicates a mechanical obstruction.
There is a very visually descriptive radiological sign mentioned in the sources here called the string of pearls sign. What does that mean?
It is a beautiful but ominous finding. You have to picture the inner lining of the small intestine. It isn't perfectly smooth. It has numerous circular folds called the valvulae conniventes.
Valvulae conniventes.
These folds exist to increase the surface area for nutrient absorption. When the bowel becomes massively dilated and almost completely filled with stagnant fluid, those folds stretch out but still form slight ridges along the top wall of the tube.
Okay, so it's a pipe mostly full of water with little ridges along the ceiling.
Exactly. Now imagine tiny microscopic bubbles of bacterial gas trying to float to the top. Because the pipe is mostly full of fluid, the gas can't form a massive dome.
Oh, they get stuck.
Yes. Tiny individual bubbles of gas get trapped between those mucosal ridges along the top edge of the fluid. On an X-ray, those tiny, evenly spaced bubbles lining up in a row look exactly like a string of pearls draped across the abdomen.
That is fascinating physics.
Yeah.
The third sign of the triad.
A gasless colon. If there is a massive traffic jam in the small intestine, absolutely no air or gas is making its way downstream. So the colon, the large intestine, appears completely empty and collapsed on the X-ray.
So X-rays are fast and cheap, but the sources are very clear that they are not enough. They have a sensitivity of maybe 79 to 83%.
Right.
They can tell you that the bowel is dilated, but they can't tell you what the barricade is. And crucially, they have a terrifyingly high false negative rate for those deadly closed-loop obstructions. Why is that?
Because of the fluid dynamics we just discussed.
Yeah.
In a closed loop, the trap segment is often entirely filled with fluid with no air at all.
Okay.
X-rays rely on the contrast between dark air and white tissue or fluid to see anything. If a loop is just a solid mass of fluid, it blends in perfectly with the surrounding organs. It might just look like a vague, hazy gray mass on an X-ray. You would completely miss the strangulation.
So if the fast, cheap option fails to give the full picture, we move to the gold standard of abdominal investigation.
We move to the CT scan, specifically a multi-detector, contrast-enhanced computed tomography scan. This machine is the absolute workhorse of modern abdominal imaging. It slices the body into microscopic cross-sections. It boasts a sensitivity of over 90% and an accuracy of 95% in diagnosing obstructions.
Now, there is a highly specific technical detail regarding the CT scan protocol in the sources. Anyone who has ever had a normal abdominal CT scan knows the drill.
The chalky drink.
Yeah, exactly. They hand you a massive, heavy plastic jug of chalky, gross-tasting oral contrast, usually barium or iodine-based, and force you to drink it an hour before the scan. The liquid travels down and lights up the inside of your stomach and intestines on the image.
Right.
But for a suspected small bowel obstruction, the guidelines explicitly shout, do not give oral contrast. Why? It seems like you'd want to see the inside of the tube.
Giving oral contrast in this specific scenario is a massive clinical error for two crucial reasons. The first is pure patient safety. The patient's stomach and upper intestines are already massively dilated and backed up. They're already experiencing severe nausea.
Yeah, that makes sense.
If you force them to chug a liter of dense hyperosmolar fluid, they will almost certainly suffer violent emesis. They will vomit it all back up.
And they're lying down.
Because they are lying flat on their back in a CT scanner when this happens, there is a very high risk they will aspirate that toxic contrast directly into their lungs, causing a fatal chemical pneumonia.
Okay, aspiration risk is a very good reason. But what is the diagnostic reason?
The diagnostic reason is that the bowel is already filled with backed up fluid and gas. That trapped water actually serves as a perfect, natural, neutral contrast agent to outline the inside of the tube.
Oh, I see.
What the radiologists really need to see isn't the inside of the tube, they need to see the wall of the tube. To do this, they give intravenous, or 5E, contrast through a vein in the patient's arm.
Ah, so the 5E contrast travels through the bloodstream into the mesenteric arteries and lights up the living tissue of the bowel wall.
Exactly. The living perfused bowel wall will rapidly absorb the IV contrast and glow bright white on the scan. If you had filled the hollow inside of the intestine with bright white oral contrast, it would completely wash out and obscure your ability to see the thin glowing line of the bowel wall. And seeing how well that wall is glowing is the absolute only way to know if the tissue is still alive or if the blood supply has been cut off.
That makes perfect sense. You need to see the blood flow, not the stagnant water.
Yeah.
So the radiologist gets the images. They have hundreds of digital slices of the abdomen to scroll through. What is the very first thing they are hunting for?
They are hunting for the transition point. That is the holy grail of the scan.
The transition point.
They will trace the massively dilated, balloon-like, fluid-filled loops of small bowel down, slice by slice, following the twisting path until suddenly, abruptly, the bowel collapses down to a normal, tiny, flat caliber. That exact physical spot where heavily dilated meets totally collapsed is the transition point.
That is the exact site of the obstruction.
Exactly.
And once they find the exact location of the barricade, they look closely at the shape of the tissue around it to diagnose what is causing it, like those twisted closed loops. What does a twisted balloon animal look like on a CT scan cross-section?
Depending on the angle of the twist relative to the scanner's slicing plane, it creates very distinct geometric shapes. If the loop is aligned horizontally with the scan, you will see a distinct U or C-shaped loop of heavily dilated fluid-filled bowel isolated from the rest.
Okay.
You might see the beak sign.
The B set, like a bird.
Yes. If you follow the dilated bowel down to where it is twisted, the walls taper down to a sharp, tight point, looking exactly like a bird's beak pointing directly at the site of the torsion.
Oh, wow.
You might also see the fat notch sign, where the thick, fatty tissue of the mesentery is visibly dragged and compressed into the tight muscular twist.
And the most dramatic sign mentioned is the whirl sign.
The whirl sign is definitive for a volvulus, a complete twisting of the entire mesentery. If you take a cross-section right through the center of the twist, you will see a radial array of dilated bowel loops surrounding a central tight point.
Like a whirlpool.
And crucially, you will see all the mesenteric blood vessels swirling and spiraling into that center point, looking exactly like a hurricane scene from a satellite or a whirlpool. It proves the entire leaf has been twisted.
That is visually horrifying, but clinically brilliant. But the radiologist's job isn't done. Finding the block is step one. Step two is figuring out if the tissue is already dying. How does a black and white image show tissue death?
This is where that IV contrast proves its worth. They look closely at the thin wall of the bowel at the transition point.
The glowing wall.
Right. If a segment of that wall shows reduced enhancement, meaning it is glowing less brightly than the healthy bowel a few inches away, or if it shows a complete lack of enhancement and looks dark gray, it means arterial blood carrying the contrast is no longer reaching it. The tissue is ischemic. It is suffocating.
What else points to advanced strangulation?
They look for massive bowel wall thickening, indicating severe edema. They look for haziness or stranding in the normally clear mesenteric fat, indicating massive local inflammation. They look for free fluidocytes pooling in the dependent areas of the abdomen, indicating the bowel is weeping plasma.
Now the really bad ones.
But the absolute most terrifying end-stage signs are pneumatosis intestinalis and portal venous gas.
Let's break those down. Pneumatosis intestinalis sounds like air where it shouldn't be.
It means there are actual physical bubbles of gas trapped inside the muscular layers of the intestinal wall itself. Not in the hollow lumen, but embedded in the meat of the tissue.
How does gas get inside the solid muscle?
It means the tissue is so profoundly necrotic, so dead and structurally compromised, that the fermenting bacteria from inside the lumen have literally invaded into the muscle wall and are producing gas pockets inside the rotting tissue.
Oh, wow. And portal venous gas.
Portal venous gas is the next fatal step. It means that the bacteria-produced gas has completely breached the dying bowel wall, entered the collapsing veins, and those tiny gas bubbles are actively being swept up through the bloodstream directly into the liver.
That sounds unrecoverable.
If a radiologist sees portal venous gas, the patient is in active septic collapse and requires immediate, heroic emergency surgery to have any chance of survival.
Okay, to step back from the brink of death for a moment, there is one more CT sign mentioned in the literature, and it is so biologically bizarre I have to ask you to explain it.
Sure.
It is called the small bowel feces sign, or SBFS. What on earth is happening there? The small bowel handles liquid soup. It isn't supposed to have feces in it.
It is a fascinating, highly specific, and slightly grotesque radiological sign. You are correct. Normally, the small bowel contents are entirely liquid. The material does not turn into solid, recognizable feces until it reaches the large colon where the water is actively extracted. But imagine a chronic or subacute obstruction, like a slow tightening adhesion. The fluid hits the barricade and sits stagnant in the small bowel for days.
The highway is stopped for a week.
Yes. Over those days, the small bowel wall, despite being damaged, slowly absorbs whatever water it can. Simultaneously, the trapped bacteria work aggressively on the stagnant food particles.
Okay.
This combination of slow desiccation and intense bacterial putrefaction creates a mottled, heterogeneous mixture of trapped gas bubbles and semi-solid particulate matter. On a CT scan, this mixture mimics the exact visual texture of normal colonic feces.
It's incredible. The body is so severely backed up that it just throws up its hands and tries to process waste in the completely wrong organ.
Exactly. And when a radiologist spots the small bowel feces sign on a scan, it is incredibly helpful clinically.
Why is that helpful?
Because this highly processed, stagnant material almost always sits immediately proximal to the barricade. It acts like a giant glowing neon arrow pointing directly at the transition point.
So while the CT scanner is the main event, the doctors are also drawing blood and running laboratory tests in the background. What are they looking for in the blood?
Blood work is rarely used to diagnose the physical obstruction. The imaging does that. The labs are used to assess the systemic physiological damage the obstruction has caused.
Okay, like a CBC.
They will run a complete blood count, or CBC. They are looking for an elevated white blood cell count. A massive spike in white blood cells can indicate extreme physiological stress, severe dehydration, or bacterial translocation, where the mucosal barrier is failing and gut bacteria are leaking into the bloodstream.
They're also checking electrolytes, given how much the patient is vomiting.
Yes, a basic metabolic panel is critical.
Mm.
You will see dropping potassium hypokalemia and dropping chloride hypochloremia from the emesis. You will look at kidney function tests, blood urea nitrogen, and creatinine. These will spike sharply, indicating acute kidney injury secondary to severe dehydration.
But there is one specific lab test that seems absolutely crucial for detecting that hidden ischemia, the tissue death, before it shows up on a scan. Lactate. Serum lactate is a vital biomarker here. To understand why, you have to remember basic cellular biology.
Okay.
Normally, our cells use oxygen to burn glucose for energy aerobic metabolism. The byproduct is harmless carbon dioxide.
Right.
But when the bowel is obstructed and the blood supply collapses, the tissue is abruptly deprived of oxygen. The cells don't just instantly die. They panic and switch to a backup generator. Anaerobic metabolism.
They burn fuel without oxygen.
Exactly. But the primary toxic byproduct of anaerobic metabolism is lactic acid. If a patient with a known bowel obstruction has a climbing serum lactate level, it is the biochemical equivalent of the bowel screaming. It means the tissue is actively suffocating.
Wow.
An elevated lactate level has a 90% sensitivity for bowel ischemia. It tells the surgeon that the window for observation has slammed shut. And if we pull back and look at the bigger picture of this diagnostic detective work, it becomes incredibly clear why the advent of the modern CT scan utterly revolutionized abdominal surgery.
Oh, completely.
Before CTs, a surgeon looking at a vague, fuzzy X-ray just knew if there was an obstruction somewhere in the abdomen. They had to guess. They didn't know exactly where it was, they didn't know what was causing it, and crucially, they couldn't see the blood flow to know whether the tissue was already dying. The CT scan removes the guesswork. It dictates the exact surgical timeline.
And that timeline brings us to the most notoriously difficult part of the entire process, the management dilemma.
Yeah.
The detective work is complete. The CT scan confirms an obstruction, the transition point is identified, and it looks like a dense adhesion band from a prior appendectomy. There are no signs of immediate ischemia. The tissue is alive, but blocked.
So no dead tissue yet.
Right. Now, the medical team faces a massive high-stakes decision. Do they wait it out and see if it clears, or do they rush you to the operating room to cut you open?
To a layman, it seems like the simplest choice in the world. If there's a physical band of scar tissue choking my intestine, go in there and cut the band. Why is there a debate? Let's start by looking at what happens if they decide to wait. This path is called non-operative management, or NOM. What does it actually involve to medically wait out a barricade?
Non-operative management is essentially putting the entire gastrointestinal tract into a medically induced coma to let it rest. The patient is immediately made strictly MPO-nil porose, which means absolutely nothing by mouth. Not a cracker, not a sip of water, not an ice chip. You have to stop adding volume to the traffic jam.
But the body is still producing saliva and gastric juices, right? You can't turn off the stomach entirely.
Which is why the second and highly unpleasant step is inserting a nasogastric tube, or NGT. The doctor takes a long, flexible plastic tube, pushes it up the patient's nose, down the back of their throat, down the esophagus, and deep into the stomach.
That sounds miserable.
It is incredibly uncomfortable, but it is life-saving. The outside end of that tube is hooked up to a continuous wall suction unit. The machine acts as a constant vacuum, physically sucking out the liters of swallowed air, saliva, gastric acid, and backed up bile.
So you are actively deflating the balloon from the top.
Exactly. It provides immediate mechanical decompression of the stomach and upper bowel, relieving that agonizing stretching pressure.
And the dehydration.
Because the patient cannot drink and the machine is sucking out their fluids, they are pumped full of aggressive intravenous fluids and electrolytes to keep the kidneys functioning. And then the team initiates strict observation, serial abdominal exams every few hours, continuous vital sign monitoring, and agonizing waiting.
Just waiting for the adhesion to magically let go. How does waiting fix a superglued scar band?
The adhesion band itself doesn't change, but remember, the bowel wall trapped under the band is massively edematous. It is swollen with fluid. Sometimes just relieving the internal pressure with the NG tube allows that wall swelling to subside.
Oh, I get it.
If the tissue shrinks just a few millimeters, the bowel might be able to spontaneously wiggle itself free from the kink, and the obstruction resolves. But we don't just have to sit and wait blindly. There is a pharmacological trick we can use during this waiting period to force the issue: gastrographin.
Now, wait a minute. Gastrographin is a water-soluble contrast medium, right? It's used for imaging. It's essentially exactly the same stuff we just said not to give orally before the CT scan because it makes people vomit.
Yeah.
Why on earth are we giving it to the patient now?
This is one of those brilliant, serendipitous medical accidents. Gastrographin was originally designed purely as a dye to show up brightly on X-rays, but decades ago, doctors noticed something strange.
What's that?
Patients who drank gastrographin to see where their obstruction was often miraculously had their obstructions resolved shortly after drinking it. They realized gastrographin possesses a profound therapeutic magic.
What makes it magic?
It's physical chemistry. Gastrographin is extremely hyperosmolar, meaning it is incredibly dense with solute particles compared to human tissue. When this dense, salty fluid hits the dilated small intestine, physics takes over. It acts like a powerful molecular sponge. Through osmosis, it rapidly draws massive amounts of water out of the swollen, edematous bowel wall and pulls it directly into the hollow lumen.
Oh, I see. It acts as an internal dehydrator for the tissue.
Exactly. It aggressively shrinks the physical swelling of the intestinal wall. By decreasing the bowel wall edema, the outer diameter of the tube becomes physically narrower, making it much more likely to slip through the tight, unyielding adhesion band.
But if it's pulling water into the tube, isn't it adding to the traffic jam volume?
It does add volume to the lumen, but that sudden, massive influx of water serves a second purpose. It heavily stimulates the intrinsic nervous system.
Right.
The smooth muscle senses this massive volume and triggers a powerful coordinated wave of peristalsis that can physically push through and break the obstruction. So the gastrographin serves a dual purpose, diagnostic and therapeutic. They administer it down the NG tube. Then they take an X-ray 24 hours later. If the contrast dye has made it all the way through the small bowel and is visible in the colon, the doctor smiles. The obstruction is broken. The barricade is clear. Surgery is avoided.
That is an incredibly elegant solution. But there is a very strict time limit on this waiting game. The medical guidelines talk about a 24 to 48-hour window to see if the gastrographin works, and a hard, absolute 72-hour limit for overall conservative management.
Yes.
Which brings me back to my initial pushback. Why wait 3 days with a plastic tube down your nose, risking tissue death, just to see if a hyper-salty drink works? Isn't it fundamentally safer and faster for a surgeon to just make a tiny incision, go in, and physically snip the scar band immediately?
You have just articulated the ultimate agonizing catch-22 of general surgery. Surgery is, without question, the absolute best, most definitive way to fix a single adhesion.
Right.
You go in, you cut the scar band, the bowel springs free, the plumbing is restored, problem solved. But surgery is also the primary, overwhelming cause of future adhesions. Every single time a surgeon opens the abdomen, every time they touch the bowel with a metal instrument, every time they expose the delicate mesothelium to the air, they're laying the groundwork for a massive new cytokine storm.
The same storm we just talked about.
Exactly. They are triggering the exact macrophage invasion and fibrinolytic failure that caused the problem in the first place.
You fix one barricade today, but you plant the seeds for 5 new barricades next year.
Exactly. If you operate on a 40-year-old patient for an adhesion today, you might create new adhesions that obstruct them at 42, so you operate again, which creates more severe adhesions, obstructing them at 45. It is a vicious compounding cycle.
That's horrifying.
I have seen patients who have had 10, 15 abdominal surgeries, their intestines fused into a solid block of concrete-like scar tissue, trapped in a lifelong cycle of operations. Therefore, cutting a patient open is delayed as long as it is physiologically safe to do so. You do everything in your power to avoid the knife.
But the surgeons can't always wait. There are strict indications for when non-operative management is abandoned and urgent operative management is initiated. According to the Canadian Association of General Surgeons guidelines, and fully supported by the World Society of Emergency Surgery, surgery is immediately triggered under specific conditions.
Yes. The absolute drop-everything triggers are signs of ischemia. If the patient develops peritonitis, meaning their abdomen becomes rigid, board-like, and exquisitely painful to even a light touch, indicating the bowel is leaking bacteria, you rush to the OR.
Right.
If the CT scan shows portal venous gas, pneumatosis, a closed loop twist, or dead tissue, you rush to the OR.
But what if it's just a simple obstruction? No dead tissue, but the patient is miserable.
Even then, the guidelines provide a predictive model. They found that the presence of 3 to 4 specific clinical risk factors gives a 70 to 90% predictive certainty that conservative weighting will fail.
What are the factors?
Free fluid pooling on the CT scan, severe mesenteric edema on the CT, a strong clinical history of intractable vomiting, and interestingly, the lack of that small bowel feces sign we discussed. If a patient presents with all of these, the data says that waiting 72 hours with an NG tube is likely futile, and you should just operate early to save them the misery.
Are there any other reasons to skip the waiting period?
Yes. If the patient has a virgin abdomen, meaning they have never, ever had a prior abdominal surgery in their life, it is highly, highly unlikely that the obstruction is caused by an adhesion. Your body doesn't just spontaneously form superglue without prior trauma.
Which means the barricade is something else.
It implies the barricade is a newly grown tumor, an undiagnosed inflammatory stricture, or an internal hernia. None of those will magically resolve with an NG tube and gastrographin. They require surgical resection. So virgin abdomens go to the OR much faster. And lastly, the hard rule. If they have been on NG suction for 72 hours and there is absolutely no clinical resolution, you must operate. The risk of sudden ischemia after 3 days of pressure is too great.
Okay, so the agonizing decision is made. We have to cut. How do the surgeons physically approach this? Do they unzip the whole abdomen down the middle, or do they try to use the tiny cameras?
The surgical approach depends heavily on the severity of the dilation and the patient's surgical history. But the modern guidelines, specifically from the Eastern Association for the Surgery of Trauma, have strongly validated the laparoscopic approach for suitable candidates.
Right.
If the bowel isn't so massively dilated that it completely blocks the camera's view, a laparoscopic adhesiolysis, cutting the adhesion through tiny keyholes, is the preferred initial approach.
The statistics on the benefits of laparoscopy and the sources are incredible. Comparing laparoscopic to open surgery, you see shorter operative times, 77 minutes versus 94 minutes.
Right.
You see massive life-changing drops in the length of hospital stay, 2.7 days in the hospital for laps versus nearly 10 days for open. And most importantly, an incredibly lower 30-day mortality rate, 1.3% for lap versus 4.7% for open.
Those numbers are compelling, which is why surgeons push for it whenever possible. Crucially, the tiny keyhole incisions and the enclosed environment cause drastically less trauma to the peritoneal mesothelium. This means you are significantly reducing the risk of forming new adhesions compared to an open laparotomy.
Makes sense.
However, it is not a magic bullet. There are grave, terrifying caveats to the laparoscopic approach.
What makes it so dangerous?
Imagine the physics of the operation. You have a bowel that is normally the thickness of a thumb, but is now dilated to the size of a fire hose.
Right.
The wall is paper thin, edematous, and incredibly fragile, like wet tissue paper. The surgeon is trying to manipulate this massively swollen, slippery organ using foot-long metal chopsticks while looking at a 2D monitor lacking direct tactile feedback.
That sounds like a recipe for a puncture.
It is. The data shows a 7% enterotomy rate for laparoscopic adhesiolysis.
7%.
That means in 7 out of every 100 cases, the surgeon accidentally nicks, cuts, or tears a hole in the fragile bowel wall with their instruments. That is a disastrous intraoperative complication. You suddenly have highly infectious, pressurized liquid feces leaking into the sterile abdomen you are trying to fix.
Oh.
You immediately have to convert to an open surgery, wash out the entire abdomen, and resect the damaged bowel.
Which explains the other major statistic.
The 29% conversion rate. Nearly a third of the time, the surgeon starts with the tiny cameras, looks inside, realizes the bowel is too dilated, the adhesions are too dense, or the risk of tearing is too high, and they have to make the difficult call to convert to a full, open, midline laparotomy anyway.
It is a staggering tightrope to walk. You are damned if you cut, damned if you don't. Which leads us perfectly into our final section. If surgery to fix the mechanical problem fundamentally causes the precise biological problem, how do we break the cycle? Can we prevent this? We transition now to the quest to prevent these obstructions before they ever happen in the first place.
You have just named the absolute holy grail of modern abdominal surgery. If we could eliminate adhesions, we would eliminate half the emergency general surgeries in the world.
Wow.
The cornerstone of prevention, first and foremost, is meticulous, obsessive surgical technique.
What does that mean in practice?
Surgeons must practice gentle handling. They must actively treat the bowel like wet tissue paper. They cannot just grab it and yank. They must minimize the use of electrocautery, the tool that uses heat to seal bleeding vessels, because burning the tissue creates dead zones of necrosis that are highly adhesiogenic.
Okay.
They must perform thorough, voluminous irrigation, washing out the abdomen with liters of warm saline before closing to ensure every microscopic stray blood clot or piece of tissue debris is removed, because those fibroblasts will use any debris as scaffolding to build a scar.
So it's all about minimizing trauma.
And, as we mentioned, opting for laparoscopic surgery to keep the organs in a humid, sealed environment whenever feasible.
But we know that perfect technique isn't enough, right? Even the most meticulous, gentle surgeon still damages cells. The body still reacts to the trauma. What about pharmacology? We mapped out the entire biological pathway earlier. The cytokine storm, the macrophages, the fibrin gel, the collagen builders. Can't we just drug the process, block the signals?
We have tried. Decades of research have gone into this, and it has largely been a landscape of frustrating pharmacological failures, though there is always ongoing hope.
Let's look at the pathways.
Researchers have attempted to target the late-stage fibrosis pathway. There is an experimental agent called halofuginone. Its specific pharmacological action is to inhibit the synthesis of type I collagen.
That makes perfect logical sense. If you stop the fibroblasts from laying down collagen, you stop the permanent scar band from forming.
Does it work?
It works beautifully in rats. It drastically prevents adhesions in animal models. But translating that systemic antifibrotic effect to humans is incredibly dangerous.
Why? You cannot just turn off collagen production systemically, because the patient needs collagen to heal the actual surgical incision in their abdominal wall. If you stop all collagen, their incision will burst open.
Okay, so stopping the scar building is too late. What about moving upstream and targeting the initial inflammation? We all take Advil when we twist an ankle to stop swelling.
Systemic anti-inflammatories, like NSAIDs and specific KIOX2 inhibitors, have been heavily tested. The logic is sound. Stop the initial macrophage cytokine storm, and you stop the downstream adhesion. But they present a fatal paradoxical danger.
Another catch-22.
Yes. While high-dose anti-inflammatories do measurably reduce adhesions, they fundamentally impair necessary life-saving wound healing. If a surgeon removes a piece of dead bowel and sews the two healthy ends back together, a procedure called an anastomosis, that connection must undergo a localized inflammatory healing process to seal watertight.
Oh, I see.
If you give the patient powerful NSAIDs to prevent adhesions, you prevent that anastomosis from healing. It breaks down, causing a fatal anastomotic leak of feces into the abdomen.
So you can't stop the collagen, and you can't stop the inflammation. What about attacking the fibrin scab directly? We talked about the lack of natural TPA causing the permanent gel. Can't the surgeon just spray artificial TPA into the abdomen before closing up?
Fibrinolytic agents like TPA, streptokinase, or urokinase have indeed been tested to melt the fibrin matrix before it stabilizes into a scar. But again, there is a fatal physiological flaw.
Hemorrhage risk.
Massive bleeding. When a surgeon operates, they create thousands of microscopic weeping capillaries. The natural fibrin gel acts as a million tiny plugs to stop that diffuse oozing. If you pour a powerful clot-busting drug like TPA into a freshly operated abdomen, you melt all those necessary plugs. The patient might simply slowly bleed to death internally.
There has to be something in development that isn't so lethal.
There is fascinating experimental work being done with a molecule called lubricin. It is a glycoprotein naturally found in human joint fluid. It is literally the biological grease that makes your knee cartilage slippery. Researchers have experimented with spraying synthetic lubricin into the abdomen of rat models. The idea is to fundamentally alter the surface tension of the bowel, making it so incredibly slippery that the fibrin gel physically cannot stick to it.
Yeah.
It dramatically reduced adhesions in the lab, but human clinical trials to prove its safety and efficacy are still a long way off.
So if systemic drugs are too risky because they stop all healing or cause bleeding, what about localized physical barriers? It makes total mechanical sense. If I am painting two wooden boards and I don't want them to dry stuck together, I just place a sheet of wax paper between them while they cure. Why haven't we perfected a simple biological non-stick coating yet?
Barrier agents are currently our best, most widely used preventative tool, but they are far, far from perfect. The goal is to provide a physical separator that exists only during the critical 5 to 7 day physiological window when the fibrin is stabilizing into collagen.
What do these barriers look like?
One of the most famous is Seprafilm. It is a bioresorbable translucent membrane made of modified hyaluronic acid and carboxymethylcellulose. It looks and feels exactly like a thin sheet of brittle cellophane.
Interesting.
Before the surgeon closes the abdominal wall, they carefully lay these delicate sheets directly over traumatized areas of the bowel. Within 24 hours in the wet environment, the sheet absorbs water and turns into a thick, viscous, slippery gel that physically blocks the neighboring tissues from touching. About a week later, it safely dissolves and is cleared by the body.
That sounds like exactly the solution we need. Why isn't it a 100% cure for the problem?
Because of the immense, unforgiving biological difficulty of creating a substance that perfectly discriminates between bad scarring and good scarring in a microscopic space, you want the Seprafilm to stop the adhesion between two loops of bowel. But you absolutely must allow the surgical incision in the abdominal wall or the suture line in the bowel itself to heal and seal tightly.
And the gel doesn't know the difference.
It is dumb physics. If a slippery barrier agent accidentally slides a few millimeters and gets lodged between the edges of the bowel the surgeon just meticulously sewed together, that seal will fail.
Oh, no.
In fact, clinical studies have shown a terrifying increase in anastomotic leaks and subsequent mortality when Seprafilm is inadvertently wrapped around suture lines. The moderate efficacy of these barriers is deeply frustrating to surgeons. They statistically reduce the severity and density of adhesions, making future surgeries easier, but they rarely eliminate them entirely.
It really highlights what a profound biological engineering problem this is. And looking back at surgical history and the sources, before we had these high-tech hyaluronic acid films, surgeons got incredibly creative and, honestly, somewhat desperate, trying to solve this problem mechanically.
The sources mention these historical surgical oddities that sound like literal origami.
You are referring to the plication procedures, Noble's plication, and the Childs-Phillips mesenteric plication.
Right. These were developed in the mid-20th century. At that time, surgeons accepted that they absolutely could not stop adhesions from forming. The biology was unbeatable. So they decided to try and control how they formed.
How do you control a chaotic scar?
In a patient who suffered from recurrent, devastating blockages, someone who had been operated on 5 times and kept obstructing, the surgeon would perform a massive, heroic procedure. They would take the entire 20 feet of the small bowel out of the abdominal cavity. They would painstakingly cut down every single existing adhesion until the tube was entirely free.
Okay, resetting the board to 0.
Then, knowing the superglue was about to set again, the surgeon would meticulously fold the 20 feet of bowel back and forth like an orderly ribbon. Then, using a needle and thread, they would physically sew the loops of bowel together in this precise folded pattern.
They literally sewed the gut into a solid, immobile block. That is simultaneously genius and barbaric.
The logic was pure mechanics. The idea was to force the bowel to form safe, controlled adhesions in a neat, orderly arrangement. By fixing the bowel in gentle, sweeping curves, they hoped to prevent any chaotic, random adhesions from forming a sharp kink or a deadly closed-loop twist.
Did it work?
It was a heroic, desperate measure for desperate cases. Sometimes it worked and freed the patient from obstructions, but the complication rates were understandably horrifically high.
I can imagine.
You were putting hundreds of needle holes into the bowel wall, inviting fistula's abnormal connections, leaking feces, causing chronic, agonizing abdominal pain, and inflicting massive surgical trauma. We rarely, if ever, perform these archaic locations today, but they serve as a stark historical marker highlighting exactly how much fear and desperation recurrent small bowel obstructions instilled in both patients and surgeons alike.
Wow. This has been an absolutely massive journey. Let's do a quick recap to pull all these complex threads together. We started at the microscopic level, witnessing the fierce cytokine battles of macrophages and the catastrophic fibrinolytic failures of a healing surgical wound.
Right.
We watched that microscopic molecular failure scale up over years into thick, industrial fibrous bands that mechanically kink and strangle the 20-foot, highly intelligent factory line of the gut. We explored the terrifying fluid dynamics and physics of a closed-loop obstruction, where a twisted leash acts as a tourniquet, starting a 6-hour ticking clock of tissue necrosis.
Exactly.
We saw how modern radiological wizardry, the CT scan, with its whorl signs, beak signs, and bizarre small bowel feces signs, allows doctors to peer through the abdominal wall to find the exact transition point and measure the suffocating lactate levels. And finally, we unpacked the delicate, agonizing surgical paradox of treating this disease, where the only definitive cure with a scalpel is also the primary biological cause.
It is a remarkable, sobering testament to the immense resilience of the human body, but also a very stark reminder of the unintended, long-term consequences of modern medical intervention. We have absolutely mastered the mechanical ability to resect disease, bypass stomachs, and stitch tissues together. But we are still, fundamentally, learning how to negotiate with the immune system. We are still learning how to tell the body to stand down and stop aggressively overhealing the necessary wounds we leave behind.
Which brings me to a final, slightly mind-bending philosophical thought to leave you, the listener, with today. If you really think about the embryology and the physical anatomy of the human body, the inside of your gastrointestinal tract is actually continuous with the outside world. It is a single, hollow, unbroken tube running from your mouth down to your anus. The food you swallow, the trillions of bacteria living in your gut, they are technically still outside your body's true internal sterile environment. They're just passing through a neatly folded, wet external tunnel, perfectly encapsulated inside you.
That is an absolutely accurate, topological way to look at human anatomy. From a purely mathematical and physical perspective, human beings are essentially highly complex, fleshy donuts.
Right. We are a donut. And here's the profound irony. The greatest danger to this delicate 20-foot inner tube isn't usually what you swallow from the outside world. It isn't a foreign invader, or a toxin, or a virus. The absolute greatest threat is your own body's hypervigilant, ancient immune system, locked safely inside the sterile peritoneal cavity, trying aggressively to heal the tube from the outside in after a surgical trauma. What if the future of surgery isn't about making sharper cuts or faster cameras or developing more slippery liquids? What if the ultimate solution to the physiological traffic jam is figuring out how to temporarily locally blind our own immune system so the body simply forgets it was ever injured in the first place?
That is the ultimate biological frontier, a truly invisible surgery, where the mesothelium heals and seals without a single macrophage ever sounding the cytokine alarm.
Something fascinating to mull over the next time your stomach rumbles. Until then, keep questioning, keep learning, and we will catch you on the next deep dive.